Hello everyone. In this webinar, we will learn about Bubble CPAP, the solution for babies with respiratory distress. I am Dr. Srinivas Murki. I am the Chief Neonatologist at Ankura Children's Hospital, LB Nagar, Hyderabad. All equipment shown in this webinar are for learning purpose, and I do not have a financial agreement with any one of them, except for I'm the innovator of Merck's Precise Air Oxygen Flow device, and I have a financial agreement for this device. The objectives of this presentation are when to use Bubble CPAP, how to use it, how do we initiate, what do we monitor, when do we wean, when do we say it is a failure, how do we improve the efficacy of Bubble CPAP, and what are the learning options for knowing the science and the art of Bubble CPAP. We'll learn these objectives using this case study. This baby S is 30 weeks, 1,350 grams, a girl child born preterm because of preterm labor. The mother received antenatal steroid 6 hours prior to delivery. The baby was born by C-section. There was no asphyxia. The baby started having respiratory distress from birth. In view of persistent respiratory distress, the baby was shifted to our tertiary care NICU, and he was shifted on nasal oxygen. At admission, the baby's temperature was 36. The baby had moderate to severe respiratory distress, and the saturations were 93% on room air. Here, the respiratory distress was assessed using Silverman-Anderson score, which is a reflection of functional residual capacity of the lung. The more the score, the lower is the FRC, and more the work of breathing. So we will see how to assess the severity of respiratory distress using Silverman-Anderson score. In this video, you can see the baby has nasal flaring, the grunting, there are sternal retractions, and there is seesaw type of pattern on the upper chest, which is a chest above the mid-axillary line. Below the mid-axillary line, you can see the retractions reaching not up to the axilla, but you can see the retractions below the mid-axillary line. So here, each one of these component, that is nasal flaring, grunting, sternal retraction, upper chest, that is the chest and abdomen movement, and lower chest, the chest below the mid-axillary line, we assess and we give a score of 0, 1, and 2. For each one of these 5 components, we add up the scores and we get a maximum score of 10, a minimum score of 0. The higher the score, the more the severe distress, lesser the FRC, and increased work of breathing. A baby who has severe respiratory distress or moderate distress has low FRC, and the baby is asking us to decrease his work of breathing by giving pressure to the nose or through the endotracheal tube. So if you have a preterm baby like this and with respiratory distress or increased work of breathing, what respiratory support this baby should get? How do we give that support and what do we monitor? So all preterm babies, meaning less than 35 weeks or less than 2 kg, and if they have respiratory distress, that is increased work of breathing, mostly if they have a score more than 3, as in this child, the score was 8 by 10. So he definitely had a score more than 3. And all these babies, irrespective of the oxygen saturation, this baby should be supported on CPAP. You can start the baby either on Bubble CPAP or ventilator CPAP. We always prefer to use Bubble over ventilator CPAP. So this is an ideal candidate. A preterm baby with increased work of breathing, that means your SSI score is more than 3, is a candidate for Bubble CPAP. And the earlier you start, the better are the outcomes. So this CPAP helps to improve the lung volume, increase the FRC, decrease the work of breathing, and helps in reducing the SA score. So how do we give CPAP for such babies? Especially how do we give Bubble CPAP? For giving Bubble CPAP, you need compressed air source, you need compressed oxygen source, you need a blender, you need a flow meter, you need a servo control humidifier, which is equipped to deliver the air oxygen at the nose at 37 degrees Celsius and at 100% relative humidity. And you also need a pressure generator, which is a bubble chamber in Bubble CPAP. So combination of all this is Bubble CPAP. All of them are equally important for delivering CPAP optimally for any newborn with respiratory distress. You can also give Bubble CPAP with a ventilator, but as I said, it is ideal to give Bubble CPAP with a Bubble CPAP machine. You can use either nasal prongs or mask or Ram's cannula to deliver Bubble CPAP. The CPAP circuit is connected to the nose, or the interface between the nose and the CPAP circuit is either a binasal prong or a mask or a Ram's cannula. When you're fixing the mask, when you're fixing the nasal interfaces like nasal cannulae, you have to ensure that they're snugly fitting the nose, not over distending. If you're using the mask, there should not be any leak. So you need to connect the nasal mask, and the nasal tubing should be well supported. Likewise, in nasal prongs also, the prongs are well connected to the cap, and the cap should ideally cover the ears. Ram's cannula, logistically it is easier to apply. However, you should ensure whenever you're using Ram's cannula, the should not be snugly fitting. Unlike nasal prongs, Ram's cannula, there should be some leak around the nostrils. So once you decided to do Bubble CPAP for a baby with respiratory distress, you need to know there are 3 settings you should know. One is the flow, second is the CPAP pressure, and third is the FiO2. So normally we set with a flow of 5 liters and with a pressure of 5 centimeters, FiO2 of 30 centimeters if you are starting CPAP for a baby with respiratory distress. So flow of 5 liters, pressure of 5 centimeters, and FiO2 of 30%. So how do you set a pressure of 5 centimeters? So the water level should be up to the level in the bubble chamber, and this indicator, the tubing which is inside the water, should be displaying 5 at the level which is shown 6 here. Ideally, this should be showing 5 for you to say that the baby is getting a pressure of 5. Now, once you set, it is easy to remember the rule of 5 with 30%, that is flow of 5, pressure of 5 centimeter, and 30% FiO2. So once you set this pressure, these flows, how do you titrate further? It's very simple. For the flows, you look at the bubbles in the bubble chamber. You should be able to see continuous bubbling in the bubble chamber. If there are no bubbles or if there are intermittent bubbles, either the flow is inadequate, you need to increase the flow, or there could be leaks in the circuit or at the interface or the mouth of the baby. So if there are no bubbles, first ensure that the mouth of the baby is closed by soothing the baby, by cocooning the baby, by preventing pain relief. Never use a chin strap for an open mouth. You should try to soothe the baby rather than use a chin strap. And look for the leaks at the interface and leaks in the circuit. If the leaks are not there, then you need to ensure that you increase the flow from 5 to 6 or 6 to 7 before you say that your CPAP is not working. So you start with the flow and look for bubbles. Bubbles are not there, look for leaks. Leaks are not there, increase the flow. The maximum flow you'll use in a bubble CPAP machine is up to 7 liters. Second, how do you know that? How do you titrate the CPAP pressure? So for increasing the pressure, you push this tube inside. For decreasing the pressure, you pull the tube out. And look at the graduation at the outlet of the tube. And now it is 6, means 6 centimeter of pressure is going for the baby. And how do we increase the pressure, or when do you increase the pressure? Increasing and decreasing the pressure is to decrease the work of breathing or to improve the FRC. So if the work of breathing is high, if the distress score is high, you increase the pressure by pushing the tube in. And if the work of breathing is less, or if the baby is quiet breathing, you decrease the pressure by pulling the tube out. So you start with a pressure of 5, and if your Silverman-Anderson score is same or worsening, you keep increasing the pressure from 5 to 6, 6 to 7, 7 to 8. But if the distress score is decreasing and baby is comfortable, then you need to see for FiO2. So if the distress is worsening or if it is same, you keep increasing the pressure till you reach a maximum score of 7 or 8 centimeters. So keep looking for the work of breathing or Silverman-Anderson score to see that whether the pressure of 5 is adequate or we need to increase on. So once you take care of flow and the pressure, then you need to titrate the FiO2. So you need to titrate the FiO2 to maintain the saturation between 91 to 95%. So if a baby has hypoxia, that means saturation is less than 91% and he has work of breathing, what do? So whenever there is hypoxia with increased work of breathing, first open the lung by increasing pressure. So if the baby has hypoxia with increased work of breathing, keep increasing the pressure from 5 to 6, 6 to 7 till you see the work of breathing is come down or your SS score has come down. But if the baby is having hypoxia, that is saturation less than 90%, 91%, but there are no retractions or minimal retractions, that means the lungs are open, then you keep increasing the FiO2 in steps of 5% till a maximum of 60% for you to get saturation between 91 to 95%. So if hypoxic baby with retractions, you increase the CPAP pressure. Hypoxic baby without recessions or mild distress, you increase the FiO2 to get the saturation between 91 to 95%. Now, whenever the baby saturations are more than 95% and there are no retractions, that means the lungs are open, baby is having good saturations, what do? So if you are in a high FiO2, keep coming down on the FiO2 from 60% to come to 55, 55 to 50, 50 to 45, and come down in steps of 5 till you get a FiO2 of 30%. So, but your saturation should always be maintained between 91 to 95%. So once you come down to FiO2 30%, and if there are no retractions, keep decreasing the pressure from 7 to 6, 6 to 5. Once you are in a pressure of 5, FiO2 30%, if saturations are still good between 91 to 95 or above 95, and if there are no retractions, you come down on the FiO2 further now from 35 to 25%, 30 to 25% or 21%. Once you are on 21 to 25%, then decrease the pressure from 5 to 4. Once you are on 4 and FiO2 21 or 25%, then if there are no retractions, saturations are between 91 to 95%, baby is stable, then you push the baby onto HFNC if the baby is more than 1 kg, and if the baby is less than 1 kg, you can continue on these CPAP till the baby is apnea free for 24 to 48 hours. So in this baby who was having respiratory distress with increased work of breathing, the baby was started on Bubble CPAP with binasal Hudson prong with a pressure of 5, with a FiO2 30% and flow of 5 liters. Over the next 24 hours, the baby's SA score gradually decreased. So just by giving pressure, the lungs started opening up. The work of breathing came to 3 by 10 and the FiO2 was still 30%, flow was 5 liters because bubbles were seen. Over the next 12 hours, that is at 36 hours after starting CPAP, there was hardly any respiratory distress. So the pressure was kept at 5, FiO2 was decreased from 30 to 25%, and then CPAP was reduced from 5 to 4. And once at this point of time, since the pressure was 4, FiO2 was 25%, since the baby is more than 1 kg, the baby is positioned to start HFNC. So as the baby is more than 1 kg, we started HFNC for this baby. And when you start HFNC, you start with a flow of 5 liters, exactly like that what you're doing in CPAP. And FiO2 same that of CPAP, that is 25%. Subsequently, the baby is comfortable, breathing well, and maintaining good saturation. You come down on the flow from 5 to 4, 4 to 3, 3 to 2, and then you come down FiO2 to 21%. Once you're on 21, flow of 2 liters, you can take the baby to room air. If the baby is, however, less than 1 kg, you can continue to keep the baby on CPAP of 4, FiO2 21 to 25%, and you continue as long as there are no apneas for this baby. Sometimes small babies may not tolerate removing CPAP. They may be continued to be on CPAP for lung growth. The small pressure will help in small distension of the lungs, which will help in lung growth. So let us look at the same baby, but a different scenario. And assume that the baby was started on Bubble CPAP with the same binasal prongs, with the same pressure of 5, flow of 5, and FiO2 30%. But instead of baby improving over the next 4 hours, the baby's SA score has decreased only from 8 to 6. Baby was having hypoxia. So because hypoxia was there, that is saturation was less than 91%, and the distress score was significantly high, that means the work of breathing was high, baby is hypoxic. So the pressure was increased from 5 to 6 and 6 to 7. And FiO2 was gradually increased from 30 to 35 up to a maximum 60, but flow was kept 5 because there was bubbling seen. At this point of time, what do we do now? Baby still is hypoxic. His saturations are still less than 90%, although the score has decreased from 8 to 6 and then 6 to 5, but the baby remained hypoxic. So what do you do now? So that means even with the maximum pressure of 7, with a maximum FiO2 of 60%, the baby continues to have increased work of breathing, saying that his lungs are still not open. So what do we do now? So before we do anything else, we need to ensure that actually the pressure has reached the lung and your air oxygen mixture is reaching the lung and it is warm and humidified. So how do we know that? So if the bubbles are seen in the bubble chamber, that means there are no leaks in the circuit and the pressure is built in the interface and in the circuit. If you should be hearing the bubbles in the chest, only then you know that the pressure in the circuit has reached the lung. So if the bubbles are seen in bubble chamber and bubbles are heard in the chest, the pressure in the circuit has actually reached the lung. And how do you know humidification is accurate or optimum? You should be able to see a display of 37 degrees on the humidifier, and there should not be any condensation in the inspiratorium. Then only you know that humidification is appropriate. And ensure that the nasal interface is well fixed. It is not causing any pressure on the baby's nose, and it is not causing any pressure on the nostrils. So the fixation should be good. There should be good delivery of air oxygen at appropriate humidification to the nose, and that pressure should reach the lung. So before you say that your bubble CPAP is not working. So once you take care of this, you get an X-ray as soon as possible. And this was the X-ray of the baby. As you can see here, the baby has a lung space of 7 centimeters, 7 lung spaces. There is reticuloglandularity and there is air bronchogram. So with this finding, that means the baby typically is RDS and the baby was in a maximum setting of 7 centimeters, FiO2 of 60%. What do we do now? So at this stage, the decision was taken to do ensure, intubate, surfactant, and extubate back to CPAP. This baby could have been given surfactant much earlier. So when you start the baby on bubble CPAP 5, FiO2 30%, and if you need to increase the pressure from 5 to 6, and baby still remains have a high work of breathing and has FiO2 30 or more, then you could have given CPAP or surfactant then also. But here we have first increased the pressure and then we are giving surfactant. Pressure and surfactant are additive. They both will help in improving the FRC and decreasing the work of breathing. So by doing ensure and by giving CPAP, we expect the baby's lungs to open and the work of breathing to come down. Along with this, we also need to work on improving the supportive care, like relieve the pain, cocoon the baby, nest the baby, ensure that the orogastric tube is in place. The tip of the orogastric tube should be above the level of the tummy. The mouth should be coated with colostrum. Gavage feeding should have been started if there is no contraindication. You should maintain temperature or euthermia, should avoid hypoglycemia, maintain the sugars, avoid hypocalcemia, treat anemia, polycythemia if it is there. And if there is acidosis, sometimes fluids or inotropes need to be started to ensure that apart from giving CPAP and surfactant, we are giving appropriate adjuvant care. And if baby is less than 1250 grams, maybe there is a role for giving caffeine and to prevent apneas and also to improve the lung function. So this baby was given CPAP, surfactant, and good adequate supportive care. All things were taken care to ensure that the pressure is reaching the lung, humidification is appropriate, interface is all right. And then over the next 12 hours, the baby's SA score has dramatically come down to 3/10. Saturations were well maintained and the FiO2. Now the pressure was 7, FiO2 was 60%. The work of breathing has come down. That means the lungs are opened up. So over the next few hours, they have decreased FiO2 from 60 to 55, 55 to 50 till a lower level of 30%. And then when the FiO2 came to 30%, the pressure was reduced from 7 to 6, 6 to 5. So while the baby was on 5 and FiO2 30%, there should be minimal work of breathing and the saturation should be between 91 to 95%. Otherwise, these changes in pressure should be gradual. Maybe for decreasing, you can wait for 4 to 6 hours. And when the work of breathing is higher, if you want to increase the pressure, wait for 10 to 15 minutes. While increasing, wait for 10 to 15 minutes. While decreasing pressure, you wait for 4 to 6 hours to decrease the pressure from 7 to 6 and 6 to 5. So this baby was brought down FiO2 to 30%, pressure from 7 to 6 and 6 to 5. And over time, the pressure was further decreased. So FiO2 further decreased to 25% and pressure from 5 to 4. When the baby was in a pressure of 4, FiO2 25%, the decision was taken to shift the baby to HFNC. So when do we say babies fail CPAP? If the pressure requirement is more than 7 centimeters and FiO2 is more than 60, baby continues to have increased work of breathing and your saturations are less than 91%, that is the time we say that baby has failed CPAP. And then you need to either see why your CPAP is not working. Are there any leaks? Are there any problem in the interface? Is the humidification all right or not? Have you given surfactant? Have you given good supportive care? If you've done all that, then maybe you need to switch over to nasal IMV or mechanical ventilation. So failure is on maximum settings if the work of breathing is still there and if your saturations are less than 91%. So what all we can do to ensure that baby's success on CPAP is improved? So there are multiple methods you can all work on to improve the success of bubble CPAP. The first important start is start early. Start in the delivery room. The earlier you start, the better is the success. Always look at a constant interface. Consistency of interface is more important than any particular interface. If you're using mask, continue to use mask so that your risk of failure will come down. And for any bubble CPAP machine, you need to ensure that you have compressed air source, compressed oxygen source, a good blender, and a servo humidifier able to deliver the gas at 37 with 100% relative humidity. And how do you know humidification is appropriate? 37 display, no condensation in the inspect limb. Monitor the baby, monitor the interface, and monitor the machine frequently so that you are not failing on CPAP. Simplify the setting. Remember the rule of 5 and 30% so that all the nurses in the unit should be able to do bubble CPAP on their own. And always know the troubleshoot, which we'll discuss further to ensure that we are not missing on any important points for success of CPAP. And adjuvants like caffeine, feeding, minimal enteral nutrition, coating of mouth, developmental supportive care, pain relief, all would help in improving the success of bubble CPAP. And if you're using bubble CPAP and you're using Ensure, always ensure that there is a backup ventilation or backup respiratory support is available. So as I said, any one of the interface is ideal or good. So you can use a prong or a mask or a RAM cannula. It depends on the unit and consistency is what will give you better results. CPAP machine, you need compressed air source, compressed oxygen source, a good blender, a flow meter, or a good humidifier and a bubble chamber or a pressure generator. If you're not having compressed air source, you can still use CPAP by using a cylinder oxygen, but for that you need a device which has an inbuilt compressor, and this is the Merck's Precise Air Oxygen device which has an inbuilt compressor for air. You can use a compressed oxygen from cylinder and it has an inbuilt blender and you have a flow meter. So this is a combination of compressor, blender and flow meter. It also helps you to monitor the pressures delivered and the FiO2 is monitored. So you can actually see how much FiO2 is delivered to the patient. So this is nothing but a replacement of compressed air source, blender and FiO2 monitoring. So always adding kangaroo mother care or skin to skin contact with bubble CPAP, especially once the baby is stable, will definitely improve the overall care of the babies and your outcome of babies, especially the neurological outcome is going to be better when you mix skin to skin or kangaroo care with bubble CPAP. So good monitoring is also important. You need to monitor the heart rate, respiratory rate, capillary refill time, breath sounds, and abdominal girth. At the patient interface, maintain the distance between the cannula and interface. Ensure that there's no blanching of the skin. Ensure that the columella is there is no septal excoriation. Nasal secretions have been cleaned. OG tube should be in place and above the level of stomach. Bubble should be seen, bubble should be heard, temperature display should be all right. The circuit should be below the level of the baby, and the flow should be between 5 to 7 and never more than 7 liters. So you can have a simple chart like this in the NICU to ensure that the nurses are aware how do we start, how do we initiate, how do we go up, and the troubleshoot. So this is a simple chart which can be put on all NICUs for better optimization of CPAP. The troubleshoot, as I've already discussed part of it, there is hypoxia and work of breathing. Either your pressure is not reaching the lung or your lung is bad. So if you have hypoxia and retractions, first take care of interface, leaks, and if they are taken care of that, the lung is still having hypoxia work of breathing, then increase the pressure or use surfactant or use a different mode. However, if the saturations are low, that is hypoxia, no retractions, and air entry is good, that means there is no problem with interface, no problem with CPAP, it's only hypoxia. So either it could be heart disease or PPHN or blender malfunction. You might set 30%, the baby is getting only 21%. So that blender malfunction should be cross-checked using a FiO2 monitor. If there is condensation in the inspiratory limb, most likely your room is very cold or your heater wire is not working or the temperature probe on which should be under the warmer is outside the warmer. If there is, you should expect some condensation or some mist in the expiratory limb. If it is not there, either your room temperature is too high or there is no water in the humidifier chamber or your chamber itself is not working. A CPAP audit tool is a good way to check whether you are optimizing the use of CPAP in your unit. So the learning options are preterm care package. These videos are available on the YouTube. Type preterm care, eliminating-ROP.com. You can look at videos on my YouTube channel. You can buy a book from Noble, or you can attend a CPAP workshop done by NNF or IAP NeoChap or any other organization, or spend 15 days in a unit so that you can optimize and learn the CPAP better. So thank you all for a patient hearing, and I'm hoping that you all will work to improve the outcomes of respiratory distress and by optimizing the use of CPAP. Thank you, one and all.